Guys, this is part two of the abdomen GI contrast studies for the GI system. Okay, we're going to start out with an anatomy review of the small intestine. So the small intestine, this is a close-up of just the duodenum, but the villi are located throughout the small intestine, not just the duodenum. But the picture on the right is just the initial C loop of the duodenum. The C loop houses the pancreas. The head of the pancreas is tucked into the middle of the C loop, just below the stomach. So that top opening there, the duodenal bulb connects to the pyloric sphincter to kick things off, and then it goes through the descending region. And on the inside of the C loop curve, that's where we find the papilla, that is the entrance of the hepatopancreatic system. Both the pancreatic duct and the common bile duct enter, or have a exit point rather, into the small bowel on the inside of that C loop. Okay. Now the hepatobiliary system, that's a separate lecture from this one. Okay, and we'll get into more detail of the biliary system, the liver, the gallbladder, the hepatic ducts, common bile duct, pancreatic duct, all of those. I believe that's a separate lecture from this. Okay. So the third region of the duodenum is a horizontal section, and then there's a slight ascending section, and as you get to the end of the C, that's when it transitions to the jejunum at the first flexure after the C. Okay, and then it kind of winds like a bowl of pasta from that point on. It's mostly the upper section is mostly jejunum, and then it descends into the pelvis and it becomes the ileum. Okay, all along the inside mucosal layer of the small bowel are these tiny little finger-like projections that have lots of surface area. Those are the villi. That's the parenchymal tissue, if you will. That's the villi is the part of the small bowel that actually absorbs the nutrients from the food boluses as they pass by. The peristaltic action in the small bowel is more of a back and forth motion than it is in other sections of the GI tract. And the back and forth motion, the oscillation of the food bolus past the villi, makes it so that we get more complete absorption, or at least that's the idea, more complete absorption of the nutrition that you ingest. That's the primary physiological function of the small intestine, is just to absorb the nutrients from the things you eat. Okay, so your small intestine is approximately, not always, but approximately 22 feet in length on average, from the pyloric sphincter to the ileocecal valve. The first C loop is the duodenum, sometimes called duodenum, depending upon which lecturer you're listening to. Okay, I call it the duodenum. The second section is the jejunum, and then the terminal section is the ileum. Okay. The peristaltic motion is a back and forth motion through these portions. So with a peristaltic action, you know that there is a smooth muscle band surrounding the entire small bowel, and there's an intermucosal layer. Okay. Oh, look, a review question from the previous recorded lecture from part one. Which position may be used to demonstrate a hiatal hernia? Okay, and the right answer is Trendelenburg. Remember, we're going to play with the difference in pressures between the thoracic cavity and the abdominal cavity, and we're also going to instigate a Valsalva maneuver where the patient bears down and strains like they're having a bowel movement on full expiration, and then bear down and strain. That's a complete Valsalva maneuver. That's going to make extremely low pressure in the thoracic cavity and extremely high pressure in the abdominal cavity. And if there is an opportunity for liquid to reflux back into the esophagus, it will do so. And typically that's how you get the barium to reflux. You force a reflux condition, and then of course if there's a hyoidorrhea present, it will show itself with the refluxing barium. So yeah, Trendelenburg position, head down, feet up. That way gravity assists with that. The pressure difference helps, but gravity also assists with encouraging or exacerbating that esophageal reflux. All right, so your small intestine procedures, typically you just fill the small bowel with barium and then you watch it go through. And the whole thing is about how long does it take to get to the end, okay? So normally it takes an hour and a half to 2 hours, okay, to get to the ileocecal valve. That would be a normal small intestine study. And you're going to take pictures either every 15 minutes or every 30 minutes, depending upon facility protocol. Now, how do you get the barium in there? Well, most of the time you just have them drink two glasses of thin barium. Okay. You can also do it. There are some other means, including reflux filling, and that would be utter torture. What you do is you overfill the large colon to maximum capacity with barium sulfate, and because of the pressure and the amount of liquid inside the large colon, it will reflux into the small intestine. Okay. That's more of a risky procedure. That's a great way to get like an upset stomach or a gastroenteritis, procedurally induced gastroenteritis. The ileocecal valve is supposed to be a one-way valve, and it's not supposed to let contents of a large colon reflux back into the small colon. So reflux filling for a contrast study of the small bowel is problematic, and it increases the risk for small bowel infection because the large colon has some bacterial colonies that are just fine in the large colon, but can actually make you sick if they reflux into the small bowel. And so the part of the ileocecal valve is to separate the contents and make it so the small bowel only flows to the large bowel. Okay. The third way to get barium into the small bowel, if the patient can't swallow, is a nasojejunal tube can be used. Okay. And you can inject through that tube. Okay. So it's a little bit longer than a nasogastric tube. Often a nasal jejunal tube is used to bypass the stomach. In the case of unexplained nausea or vomiting, you might have a patient fitted with a nasal jejunal tube, and then barium can also be introduced through the nasal jejunal tube, and they call that procedure an enteroclysis. Okay. The key thing about an enteroclysis is make sure it's not, if it's a double lumen tube or it has some kind of a balloon anchorage, make sure that you're injecting the barium into the tube that leads to the small bowel. not the dead end that leads to the anchor balloon at the end of the catheter. Okay. The other thing is you want a really good high volume flush of any nasal jejunal tube or nasal gastric tube for that matter, because if barium residue is left in the tube, it will plug and obstruct that tube, and then the patient will need the tube replaced. So any barium you do through an enteroclysis, through injection through either an NG or an NJ tube, you must flush it with a significant volume of water to make sure there's no barium sulfate residue still in the tube after you administered the barium. Okay. Most of the time we're using the oral method. Most of the time the reason we're doing a small intestine follow through is for reason of obstruction. And so the patient can swallow by mouth, they just can't keep it down because they have a small bowel obstruction. Okay. There are other ways to diagnose a small bowel obstruction, but a barium small bowel follow through is one of those ways. You can diagnose it with CT or ultrasound, but the barium one does produce the small bowel follow through. Conventional small bowel follow through does produce a definitive diagnosis, and it's definitely more radiation than an ultrasound, but it is less radiation than a CT abdomen. So we do occasionally still do a small bowel follow through. Now, if we can, we want the patient to prep for a small bowel follow through. We want a soft or low residue diet for 2 days before the study. Okay. Food and fluid withheld after the evening meal before the examination. Okay. Remember your small bowel, if it's acting normally, normal physiology, it's going to empty within about 2 hours. So a 8-hour MPO period should be plenty. Okay. A cleansing enema can be administered if absolutely necessary, but usually is not. Okay, usually that's a step too far. We don't need to go to that aggressive of a preparation. With an inpatient that has just had a barium study, you might see them order a cleansing enema regimen before a small bowel follow through. But typically when a barium contrast study is ordered, there's a certain order for those exams and the scheduling of those exams. And there's safety lockouts that if you try to order another exam within a 48-hour period, some of the ordering softwares will say the patient's not available for this exam because they had, let's say, CT abdomen pelvis with contrast just 24 hours ago, and they will still have residual barium. Okay. Some of the softwares would actually do that. Other times it's up to you to search the patient's medical record and look at what they've had recently, especially if it's an inpatient, to see if they would possibly have residual barium. Now, how do you confirm whether or not they do have residual barium or if they still have contents in the small bowel? Well, you're going to perform a scalp film, just like you do for every other GI fluoroscopy examination. Okay, so as far as the complexity of the exam, this is not very complex at all. This is taking KUBs at protocol prescribed intervals, usually every 15 minutes or every 30 minutes, post ingestion of the barium. And so the time marker, the time stamps that you put on, either by radiopaque marker, if your facility has a set of radiopaque time markers, or by embedded electronic comments. You're telling the radiologist how, for this image that you just took, how long has it been since the patient first drank the barium? And that gives the radiologist an impression of, is the small bowel running slower than normal? Okay, because the radiologist is aware of the 2 hour normal, 1.5 to 2 hour normal physiological migration due to peristalsis. The lead edge of the barium bolus should reach the ileocecal valve right around the 2 hour mark for normal physiology. Anything delayed over 2 hours, the more it's delayed, the more it looks like there is a small bowel obstruction, and the barium can't proceed past the obstruction. Okay. Back in when I first learned it, small bowel follow-throughs were always done with the patient prone, and that naturally compresses the small bowel, spreads it out a little bit more, reduces superimposition. But now the Merrill's Atlas is saying prone or supine, and there's advantages to each. Okay, so with a supine radiograph, the stomach actually, the diaphragm raises up when you lay flat on your back. The stomach rises up out of the way, and we can actually reduce superimposition of the stomach over the duodenum and the jejunum. Okay. Supine prevents compression of overlapping loops of intestine, and so you don't get as many. You could get like a pseudosine for a slow section, but that's the slow section is just on account of compression and flipping the patient into a prone position. Okay, and so you don't get a abnormal motion, peristaltic motion, if you leave them supine. If you flip them prone to take the images, it does compress the abdomen, and by compressing the abdomen, first of all, it brings the small bowel closer to the image receptor, one, so you reduce OID, increase spatial resolution, overall image quality increases, and then the small bowel, when you compress the abdomen, the small bowel spreads out in the transverse plane or laterally, and so theoretically there is less superimposition of the loops on loops of small bowel, if that makes sense. Okay. So 2 methods commonly used for the small bowel follow through. Okay. Your time intervals are usually every 15 minutes until you go to delays. Then it could be every 30 minutes or every hour. Typically there's a protocol up to the first 2 hours, either every 15 or every 30 minutes. And then you send those images to the PACS, and then you go in and have a conversation with the radiologist regarding additional films or additional images, okay, beyond the 2 hours. If you're at the ileocecal valve and there's evidence that you're at the ileocecal valve, the radiologist, as you send those images off and the radiologist sees that the barium bolus has reached the ileocecal valve and beyond, the radiologist is going to want to come in and do spot radiographs with a fluoroscope. And so you'll have to move. You can start a small bowel follow through in a conventional room, but when the radiologist is ready to do their spots, you're going to need an available fluoroscopic room. Okay, so you will be moving the patient in some cases. Okay. Now, a normal physiology, again, 2 hours, and you're going to be there. The patient's going to be have the barium bolus at the ileocecal valve. Okay. And so your standard projection here is just a straight AP or straight PA. There's no real obliques being done. This looks like a retrograde filling technique, because we have barium through the entire large colon as well. Okay. It does look like the patient has a nasal jejunal tube as well. So this might be retrograde due to obstruction, because also the small bowel loops look dilated as well. And so that's often a sign of obstruction. Okay. So AP or PA center at the intersection of the mid-sagittal plane and the iliac crest, and there are some identifiers there. So the topmost identifier on the top left, that's just a large colon. Technically, that's the descending colon section. The second indicator down, middle left, that's just a loop of small bowel. And then the third indicator down that seems to point to the right side of the image, just below the midline, that's actually indicating the ileocecal valve. Okay, so that's what those three indicator lines are on this radiograph. All right. Obviously, for straight AP or PA, center to the mid-sagittal plane, do a 30-minute interval, center at the level of L2 for the first few projections until you get past 30 minutes. And then anything past 30 minutes, you want to shift to centering at the iliac crest. You're literally chasing the bolus down. So in the first 15 minutes, the first 30 minutes, if they drank the barium, most of the thin barium is going to still be in the stomach, and you'll feel some of the duodenum and the jejunum in the first 15 to 30 minutes. And so you can center to the upper abdomen for the first two, like a 15-minute delay film and a 30-minute delay image, center at L2, the upper abdomen. But then any pictures after that, like a 45-minute or an hour or anything after that, you should be centering at the iliac crest because the lead edge of the barium bolus is working its way down through the pelvis, probably be in the pelvis in somewhere like the 45-minute mark or close to that if you're not obstructed. And so it just makes sense to take just a conventional abdomen film after a 30-minute interval, the initial 30-minute interval. So for your PA small intestine, okay, center to the midpoint of the image receptor, which would be at the iliac crest mid-sagittal plane. Open the field up to 14 by 17, but you don't need larger than 14 by 17. Your hypogenic patients, if you've laid them prone, you might have to do uppers and lowers crosswise. You might clip the fringes, the lateral fringes of the jejunum, both left and right, if you don't go a crosswise orientation with your hypersthenic patients. Okay. To reduce superimposition, spread the abdomen out more. We want to do all of our exposures at the end of expiration. And again, that's the registry question. And I told you back in October, I'm telling you now, any plain radiograph of anything in the abdomen expose at the end of expiration is the right answer. The reason is it reduces superimposition. Okay, so I've got an anatomy diagram here of the large colon now. Okay, so we're done talking about the small intestine. That's basically it. Small bowel follow through. Enteroclysis is injecting the barium through an NG or an NJ rather than having the patient drink the barium. Okay. So your large bowel starts with the cecum, which is an enlarged portion. It's usually 2 to 3 times the size of the other sections of the colon as far as the diameter goes. Okay. The cecum terminates in the appendix, okay, at the proximal end. The appendix is, it really doesn't have a function. It may have served a function at one time, but as far as modern science is concerned, modern medicine is concerned, the only function of the appendix is to get inflamed and then threaten to burst, which would cause septic shock in short order as fecal material would be spread through your peritoneal cavity. Okay. The cecum transitions into the ascending colon. The ascending colon takes a sharp turn toward the middle of the body, right at the liver, so we call that the hepatic flexure. And it turns into the transverse colon because that section of the colon seems to cross the body from the left to the right, or I'm sorry, from the right to the left, where it forms another flexure at the spleen, and so that's called the splenic flexure. They're also called the right and left colonic flexures. Okay, so the right colonic flexure is the hepatic flexure. The left colonic flexure is the splenic flexure. Okay, after the splenic flexure, it becomes the descending colon. Both the ascending and the descending colon are named for the physiological flow of the contents of the colon, which is at that point the nutrients have been absorbed. So as soon as it enters the cecum, it's no longer the meal bolus or the food bolus, it's stool at that point. Okay. And then the descending colon transitions to an S-shaped portion, which is named the sigmoid colon, which terminates in the rectum. And then the anus is the exit point for the GI system at the end of the rectum. All right. So it forms an arch around the loops of the small intestine. It basically wraps around like a picture frame to the small intestine. Okay. The large colon in its entirety is roughly 5 feet long. The individual pouches are called haustra, and the bands that form the haustra are called the tinea coli. The cecum is the expanded portion below the junction of the ileum and the colon, and the cecum is where the appendix is. Okay. Posterior medial side of the cecum is where the appendix offshoots from. So ascending, transverse, descending, and sigmoid are the four major sections of the colon. The cecum is part of the ascending colon. Why I have this slide twice, but I have this. All right, so yeah, the large colon preparation does involve a cleansing enema, of course. We're also going to restrict the diet. We're going to give stool softeners and laxatives. We're going to keep the patient MPO, but we're also going to administer a cleansing enema. Most of your outpatients will self-administer. They can pick up this kit, a bowel preparation kit, from their drugstore or their pharmacy. Okay. The reason we do a complete preparation of the bowel and get the large bowel emptied of all contents is fecal matter stool creates a filling defect in the barium, and the radiologist cannot distinguish, once you have a barium-filled colon, the difference between retained fecal matter and tumor masses. Okay, both of them create a barium filling defect, and it becomes a non-definitive study at that point. Okay, so your radiologist won't proceed unless they have confirmed that the preparation worked. So again, we're going to shoot a scout image for a barium enema so that the radiologist can visualize the empty colon and be sure that there is no retained stool. Okay. Unless the patient is in an acute type scenario like a GI bleed, severe diarrhea, or an obstruction, in an extreme circumstance, we're probably going to skip the prep and do the exam anyway in extreme circumstances. Okay.
It's on our
website. Hang on just a second. Preparing your equipment, you're going to have an enema bag. Some of them are pre-filled with dry barium powder that you'll just have to add water to. Others you will have to add suspended barium sulfate from a jug, a a large jug, kind of resembling like an antifreeze or a motor oil jug that like you would get from Walmart, a big barium jug. You're going to need probably around 2 liters of barium, regardless of which exam you do. The barium enema comes in a single contrast form and then also a double contrast form. Okay. If the patient has a stricture, a fissure, inflamed hemorrhoids, or other anal abnormalities, they might not be able to tolerate the full-size tip, the default tip that comes in the kit. You might have to switch to a smaller, basically hemorrhoid tip. Okay, switching to a smaller tip means that you also sacrifice the balloon anchor, and so the smaller tip can come out during the procedure, and it has to be affixed to the patient's backside with silk tape, very much like they affix a nasal cannula to the outside of the nose. Okay. If you're using the default tip that comes in the kit, it will have an inflatable balloon cuff, and that balloon cuff will prevent the enema tip from exiting in the midst of the procedure. Okay? And so you insert the tip, inflate the balloon inflates on the other side of the anal sphincter, and then anchors the tip inside, and the balloon prevents the tip from exiting back out the patient's anus. Okay. All right, patient cooperation cannot be understated. You have to explain to the patient what's going to happen. Okay. Now, I have spoken to this before. I think I spoke about it in Chapter 18 of the Introduction to Patient Care class. You can explain an enema without show and tell. Probably best to avoid demonstrating the apparatus to them, okay? Unless you want them to refuse, okay? You should just speak plainly. There's going to be a hose that goes up into their butt, and then we're going to, through the hose, we're going to pass this barium stuff that you can see on x-ray, and that's going to go up into their colon. Okay? When liquid hits their colon, they're going to cramp like they're having diarrhea or like they need to go to the bathroom. Like they need to go to the bathroom urgently. Okay? The patient can help reduce their discomfort and their cramping by trying to relax, doing deep breaths in and out, nice and slow. And when the cramping gets too severe, communicate to the radiologist that they can't tolerate it. And we can actually restrict the flow of the barium and slow it down until the cramping eases or subsides. Okay. All right. To actually insert an enema tip, turn the patient into the Sims position, which is lateral recumbent, and then elevated side leg, which is typically the right leg, not always. Elevated side leg is drawn forward, and then roll the patient into a forward or oblique from lateral recumbent about 30 to 40 degrees. Okay? This posture with the one leg drawn up and flexed and the patient in an oblique actually relaxes the abdomen, decreases abdominal pressure, and aids in relaxation of the anal sphincter. Okay? As you're actually starting to push, you're going to give the patient the instruction to take in a deep breath and blow the breath out slowly. As they're blowing the breath out slowly, the abdominal pressure is falling, and that's when you should begin to gently and with firm, steady pressure push the tip into their anus. Okay? Please add generous amounts of KY lubrication before you apply the tip. Okay? Once the tip is in, it should insert to no greater than 4 inches, and then you inflate the balloon cuff to anchor the tip in, and then the patient can flip over laying on their back. Okay, which will not exactly be comfortable, but that's the starting position for a barium enema. Okay. It will be your job as you call the radiologist in, tell them that the patient has the tip placed and they're ready to begin. Hang the barium bag on an IV pole no greater than 24 inches above the table level or the level of the patient's anus, which is roughly the table level. That's about 2 feet above the table. Students in my physics class will recognize potential energy in the barium bag suspended above the table because it has all the elements of a potential energy equation. It's a mass of barium. It's got a certain height off the floor and gravity is present. And so the barium has a potential energy that will become a kinetic energy as you open the clamp. Okay? The bigger the potential energy, that is the greater the height off of the surface of the table or above the floor, the faster the barium is going to flow. Okay? If the barium flows too fast, the patient will cramp. When you're mixing the barium with tap water, the water should be just below body temperature. It should be a lukewarm temperature. If the barium is too cold, then the patient will cramp. Okay, so you exacerbate cramping by having cold barium sulfate or by running the barium sulfate in too fast. Okay. Yes, lubricate the enema tip, instruct the patient to take in a deep breath, blow it out slow as you insert the tip. Okay, slowly and steadily during expiration. Okay, directly anterior 1.5 to 2 inches, then slightly superiorly. At 4 inches in, the rectum takes a sharp turn toward the posterior so the sigmoid can wrap against the inside of the sacrum. Okay, that's why we don't insert the enema tip greater than 4 inches, because at about 4 inches, the direction of the colon changes radically. Over-inserting an enema tip can cause a puncture or rupture of the anterior wall of the rectum. Okay, if there is resistance on the part of the patient, do not force past the resistance. Okay, ask the patient if they can maybe relax a little bit more, or if they're not comfortable proceeding, because if the tip can't be inserted, then you can't proceed with the exam. And so if you're getting resistance, don't force past the resistance. Check back in with your patient, have another conversation with them about relaxing. See if they have changed their mind about going through with the procedure. Okay? As soon as the patient refuses a barium enema, you are done. You don't talk them into it. Okay? All right, so PA large intestine, this is one of the series. It's either a series of 5 or 7, depending upon if you're doing dual contrast or single contrast. Obviously, the PA large intestine, you're going to do it prone, and it's the same centering as a conventional abdomen, mid-sagittal plane, iliac crest. That's where the central ray is directed. Okay. Open up to 14 by 17, maybe do uppers and lowers crosswise if your patient is hypersthenic. Okay, so here is our PA large intestine. This is a double contrast study. The patient is prone. Um, Barium is pooling in the more anterior sections of the colon, which is the cecum and the more proximal loop of the sigmoid. Both of those are anterior. The transverse colon is also anterior. Okay? The ascending and descending colons, especially near the flexures, are more posterior structures. And the distal loop of the sigmoid and the rectum are posterior structures. Okay. So we want evidence of proper collimation. That is, we don't want to clip any of the colon. If you clip any part of the colon, you need to repeat and get the part that you missed. No obliquity. The patient should be square, totally prone. Okay. Vertebral column centered. Ascending and descending portions are included, so no clipping. That's typically what you're going to clip is the lateral portions of the colon. We want all the flexures and the rectum. Okay. And again, uppers and lowers crosswise if your patient is larger than average. All right, same thing for an AP, same centering point, just flip the patient over lying on their back. Okay. And you should see that the barium in the air changes places. So the barium was in the cecum before, now it should be in the flexures. Okay. This is where I think this is a different patient and they've got way too much air. And so you don't really see a smooth transition here between barium and air, but we do have an air-filled cecum. The sigmoid, the barium and air have traded locations now. The distal loop of the sigmoid is now air-filled. The proximal loop of the sigmoid is now barium-filled. Okay. Okay. For the axial large intestine, this used to be called the Chouchard-Lépine or modified Chouchard-Lépine view. The actual Chouchard-Lépine view is banned by the Geneva Conventions as a form of torture. I will, during the lab, I will walk you through an actual Chouchard-Lépine view, and you can agree with me that, oh my God, that is torture. What were they thinking? Yes, it was a different time, the 40s and 50s and 60s. We didn't give much consideration to patient comfort. We just, is this going to be diagnostic? Can we contort the patient into a pretzel just to see the anatomy in a certain orientation? And we really didn't care much about patient comfort. The Chouchard-Lépine view has gone away. Overheads have gone away for barium minimus, but they'll still do the PA axial, which is a modified Chouchard-Lépine view. Okay. This is what it looks like. It's basically a 30-degree caudal angle applied to the pelvis, and what you're trying to do is stretch out the sigmoid colon, and you know how it twists in an S curve, you're trying to straighten out the S with the 30. So you're going to get an elongation artifact for anything that you radiograph, but that includes the sigmoid colon, and that's actually helpful because the sigmoid colon in a straight AP or PA doubles up on itself. So this actually reduces superimposition through the sigmoid colon region and the rectum. Okay, 30 degrees caudal when the patient's PA centered to the level of the ASIS. Okay, I also in clinical practice when I was doing this one, I would also go 1 inch to the left of the mid-sagittal plane because I know the sigmoid is more on the left side of the pelvis than it is on the right side of the pelvis. Okay, that was just my old school tech adjustment. That's not standard protocol as it's listed in the Merrill's Atlas. Okay, if you're doing an AP axial because your patient's geriatric and you think it's cruel to roll them onto their belly, you're just going to reverse the direction of the tube angle, go 30 degrees cephalad, and then again centered at the ASIS. Okay, open the collimation to about, I would open the collimation to about 1.5 to 2 inches below the trochanters, but also about 1.5 to 2 inches above the iliac crest. Okay. All right, doing obliques of the large intestine, PA or APs, you're going to use 35 to 45 degrees. Of course, if they're PAs, those are RAOs or LAOs. And what those will do is those will open the flexures. The oblique barium enema images will open up the flexures, so it removes the self-superimposition of the flexure areas. Okay, the RAO is going to open up the hepatic flexure. The LAO is going to open up the splenic flexure. Okay, the ascending and descending colon aligned with which flexure they're closest to also is displayed free of superimposition. Okay, and this is what that looks like. Notice you actually, while you're opening the hepatic flexure, you're actually doubling up and increasing the superimposition of the splenic flexure. So what that means is you do both the obliques for a series. You're going to do RAOs and LAOs or RPOs and LPOs. Okay. And now there's a trick for that, and it's the thumbs up trick, and I'll show you that as I'm doing the lab as to which flexure is open. You basically you make a fist, give the thumbs up, and then you put the base of your fist, the pinky finger side, right up against your flank under your rib cage, and then your thumb is tracing the path of the central ray for the projections that open that flexure. Okay, I'll show you. It's kind of hard to describe in words. Okay, so for image critique of these, obviously it says the entire colon, but really the area of interest is the flexure and either the descending or ascending colon. Okay. The sigmoid does seem to open up a little bit better, and the sigmoid separates from the cecum a little bit better on your obliques than it does. Sometimes you get overlap of the sigmoid and the cecum on the straight APs and the PAs. Okay. And again, this the same as it was before. Okay. And then that's for the splenic flexure. This is single contrast. We don't have any air bolus in there. That's why it looks a little different, but you can see the splenic flexure is partially open and the descending colon is displayed free of superimposition. Okay. So again, we want to try to see the entire colon, but again, the specific area of interest is the splenic flexure that's for the LAO. Okay. All right, doing a lateral intestine, typically this is confined to just the rectum, but occasionally you will do a full body lateral, but mostly it's a lateral rectum. You're going to shoot a lateral rectum just like you shoot a lateral sacrum. Okay, so at the level of the ASIS, 3 inches posterior from the ASIS. Okay, just turn them true lateral, hip on top of hip, shoulder on top of shoulder. Okay, sometimes the lateral rectum with a double contrast study is done prone as a cross table with the tip out. If that's the radiologist's preference, I would save this to last in the series. Thankfully, you guys don't do the series anymore, so you don't have to witness that horror. Okay. Additional projections that are done for a double contrast study, you're going to do left and right decubitus projections, lateral decubitus projections of the entire colon. So center at the iliac crest, mid-sagittal plane, and you're going to see the air fluid levels change from the left lateral to the right lateral. Okay. So for our lateral rectum, rectosigmoid area in the center, and that is achieved by centering the same way as you center for a lateral sacrum. No rotation or obliquity, so hip on top of hip, shoulder on top of shoulder, knees flexed, knee on top of knee, a true lateral recumbent position, and then you won't get any obliquity. Okay. All right. So I did go into the AP obliques. Those are your LPOs and RPOs. This is very much as far as what's visualized. And for your obliques, you can use the 45-degree angle sponge. It works just fine. But it still shows off the colic flexures. So the hepatic flexure, splenic flexure are still the area of interest. It's for all 4 obliques. So most techs will do the APs rather than the PAs because most barium enemas nowadays are on your geriatric inpatients. Our outpatients have several options that have made the barium enema obsolete, like virtual colonoscopy, the camera pill, a endoscope study. Any of those are a viable alternative to a barium enema. Okay. All right, so you can see the oblique large intestine. We can tell it's oblique because, oh yeah, look at the center. There's the Scotty dog. How about that? So the Scotty dog of the lumbar spine gives it away that it's an oblique position. You can also see the right ilia is folded up on itself. Left ilia is superimposed, but it's elongated and flattened out a little bit. The ribs are asymmetric as well. The left side ribs seem to be plunging toward the feet, while the right side ribs seem to be running a little bit more horizontal. Okay. And the hepatic flexure is open. This is single contrast, not double contrast here. Splenic flexure, again, doubles up on itself when the hepatic flexure is open. This would be an LPO projection. Okay. So decubitus views, right and left lateral decubitus. Again, you're only going to do this on double contrast studies. What's the whole point of a decubitus projection? To see an air fluid level. Well, unless you both have air and barium in the colon as the double contrast, there's no point in doing decubitus on single contrast. There's literally no advantage. Okay. But these are among the most beautiful of the barium. If there are beautiful barium images, these decubitus projections are the best looking ones. Okay. And so lay them on their side and remember right lateral decubitus. Hang on just a second. All right. So remember the nomenclature for right or left lateral decubitus. Sorry, I had a phone call there. Is right lateral decubitus means the patient's laying on the right side down. Left lateral decubitus is left side down. So the barium in the air is going to flip positions between these two projections. And that means with a thick barium with the adhesives in it, you're still going to get a thin coating of barium and you're going to get a nice air contrast study of literally the left half of the colon and then the right half of the colon consecutively. Whenever you do a right lateral decube, you're also going to do a left lat decube. Okay, and it's every time you do a double contrast. All right, so here's our right lat decube. The right side of the patient is down, and so you can see the hepatic flexure doubled up on itself and partially filled. The ascending colon and the cecum is actually superimposed behind the hepatic flexure here. The left half of the transverse colon is a nice air contrast. Most of the splenic flexure is a nice air contrast. There is some trapped barium halfway down the descending colon that is partially obscuring the view of part of the transverse colon. Okay, most of the descending colon can be visualized in air contrast, and about half the rectosigmoid region can be visualized in air contrast. Okay. And so area from the left colic flexure to the rectum is the air. So typically on the decubitus, the area of interest is the elevated side, because the non-elevated side, the side closest to the floor, is covered up with barium. It's the air contrast with a thin residual coating of barium on the internal mucous membrane that is the high diagnostic content, or the focus of the image. Okay. Single contrast, you're not going to do decubes for single contrast. You're just not. Okay. Here's our left lateral decube. So the splenic flexure is the side down. And again, this is clipped. This is a bad image for a reference image for Merrill's Atlas because the area of interest is clipped. The area of interest is the cecum and the ascending colon. It's clipped off of the top of the image here. Okay, but you can definitely see air fluid levels. You can tell the patient's laying on their side. Okay, this is a different patient, but we can see the transverse colon, most of the transverse colon in air contrast, slightly superimposed here at the bottom, coming out of the splenic flexure. Again, we've clipped the major area of interest, which is the ascending colon and the cecum at the top, but you also get a good view of part of the sigmoid and the rectum in this decubitus film. Okay. All right, that's all we had. Holy cow, I kept it under an hour. That was fantastic. All right, so we talked about the various GI procedures. Remember, this is part 2. Part 1 was all about contrast. We talked about barium. We talked about the anatomy of the esophagus, but also the anatomy of the stomach in part 1. And then in part 2, we talked about the small bowel, and we talked about the large colon. Okay. Part 1 was esophagram projections, stomach projections. Part 2 was small bowel follow through and how we go through that procedure. And then the last of part 2 was performing the projections for the barium enema, single and double contrast. And we also described preparations for all those procedures, going from minimal preparation in the upper GI and the esophagram to, just an NPO status after midnight, to more aggressive preparations for the small bowel, and then the most aggressive preparation where you are going to do a cleansing enema. The patient is going to do a cleansing enema. In most cases is the barium enema. Okay. The preferred contrast is barium sulfate in various volumes. I think for the esophagram, we said like thin barium, maybe 1 to 1.5 canisters or glasses, kind of like 12 to 16 ounces of barium sulfate. In an esophagram, you might get fizzy crystals, you might not. That's the granulated calcium carbonate. When it hits water, it effervesces. Very much like Alka-Seltzer, gives off carbon dioxide gas. If the patient swallows that rapidly, like they're doing a shot, okay, those carbon dioxide gas, that carbon dioxide gas will get trapped in the stomach, and it'll inflate the stomach like a balloon for your upper GI. Okay. The thick barium sulfate, typically for all regions, the thick stuff, whether it's in the big jug for the barium enema or if it's a single canister of it for an upper GI, they add in adhesives as additives to that thick barium, so it better coats the inner mucosal lining of the stomach and the large colon. Okay. Small bowel follow through is typically 2 glasses of thin barium. but it could be more. No fizzy crystals for a small bowel follow through unless it's in combination with an upper GI. Okay? For the large colon, you are going to prepare either a single contrast bag or a double contrast bag. Those vary. It could be that it's got dry powder already in the bag, and then you just add lukewarm tap water to it. Or it could be an empty bag, and then you have to fill it from the jug for the double contrast study because the jug has those adhesives. Okay. The BE apparatus for single contrast and double contrast looks slightly different because there is a pumping valve for the double contrast enema kit. Okay. Contraindications for barium is aspiration, risk of aspiration, and known or possible bowel perforation. Okay. The barium is fine and really is not a risk to the human body unless it gets outside of the GI tract. So if it gets into the trachea and the lungs, it's going to cause an aspiration pneumonia. If it gets into the peritoneal cavity, it's going to fester and form an infection that could go septic. And so that's why aspiration and perforation of the bowel are contraindications for barium sulfate. In those cases, usually the radiologist prefers to switch to a gastrographin, which is a water-soluble iodine contrast. The water-soluble iodine can be reabsorbed, okay, from both the trachea inside the airway. It can be absorbed through mucous membranes. It can also be absorbed from the peritoneum, and so it doesn't stay as a residue, and then it doesn't have persistence, and then it won't cause the regional infections that I just described, like the barium will. The iodine contrast will be taken up eventually it'll be absorbed and taken up by the lymphatic system and then flushed out of the patient's system through the kidneys. Okay, the barium will set up and start to fester. All right, that's all I have for you. We're going to have a robust lab for this. But as I understand it, all this is coming after the break, so you won't hear about this for a while. So y'all take care, and yeah, have a good weekend. I'll see y'all.